Hello everyone and welcome to this edition of Vetruus Bites. What we're going to deal with in this one is a practitioner's guide to biofilms. As you can see from the second slide, we're going to divide this little presentation up into 4 different sections. We're going to talk first of all about what a biofilm is. What we're then going to consider is where we actually find them. And then probably most importantly, how we diagnose a biofilm infection in practice. And then fourthly, how we're actually going to try and manage how we're going to treat these biofilm infections when we identify them. So, let's think first of all about what a biofilm actually is. And what we know from bacteria is that they can exist in 2 different forms. In acute infection, they're seen as independent cells, so cells floating about in that purulent exudate, and in this state they're called planktonic. As diseases become more chronic though, what we find is the bacteria become organised and they form these sessile aggregates which we refer to as biofilms. We often think that biofilms are actually restricted to bacteria, but you can see in this next slide that actually they can be any group of microorganisms. That may be bacteria. We certainly recognise them as yeast infections, algae or fungi. And in these situations we get cell-cell adhesion, and that adhesion also occurs to the surface, which may be of an orthopaedic implant, it may be the lining of the bladder, it may be something like a sinus. We know the cells are embedded in this self-produced matrix, which we refer to as an extracellular polymeric substance, often abbreviated to EPS. The advantages of the bacteria of EPS is that it helps in cell adhesion and aggregation, but as far as the area where the infection's actually occurring, the presence of EPS actually impedes the normal function of both antibodies and the phagocytic cells, which are an important component part of the host's immune system. As we look at this next slide, we can follow through the formation of the biofilm itself. We start off, as you can see, represented here by these pale blue rectangular shapes. These are essentially planktonic bacteria floating in that purulent exudate. The bacteria attach to the surface of whatever happens to be there, whether it's an orthopedic plate or whether, as we said, it's the lining of something like a bladder, and they grow rapidly and form a dense mat. What then happens is it then starts to produce this protective, slimy extracellular polymeric substance, this EPS, and this traps the bacteria on the surface. What then happens is we then see those bacteria continue to multiply, but they're multiplying within this EPS. And of course this then shields them not just from toxic chemicals and the body's immune system, but when it comes to treatment, they actually protect the bacteria from antibiotics. And what we know is once we get biofilm formation, those bacteria can become up to 1,000 times more resistant than the planktonic bacteria that we see as free-floating organisms in acute disease. So the next thing we have to think about, our next slide, is where do we actually find biofilms? Well, we know they're widely found in nature. We know that biofilms adhere to living tissue or indeed inanimate objects. We know if you walk along a river, when you slip on the rocks and the pebbles on that riverbed, that slimy appearance that there is actually biofilms. We know when you go and visit your son in his student flat and you look in the bathroom and they've not cleaned around the plug hole and the tap, that slimy discharge that's there, again, is bacterial biofilm. When we look at biofilms in disease, we know they can grow on all sorts of surfaces. So they'll grow on teeth, they'll grow on gums where they lead to things like gingivitis and dental decay. They'll grow within bladders where they perpetuate cystitis. They're found in lungs, particularly in people, where they contribute to a whole range of diseases. We also now know that they're found in ears, in both the external ear canal and in the middle ear. They're found in sinuses, they're found in wounds, and of course we recognise them and have recognised them for some time on implants and medical devices. We can see from these next slides that there's a whole range of different publications describing the different biofilms that we can find. I've just pulled out two papers, as you can see from this next slide, which shows one where enterococci have been found, they're capable of forming biofilms in periodontal disease, and then the second one you can see there I've particularly pulled out because it shows that yeast, particularly Malassezia pachydermatis, is capable of forming biofilms in skin disease. This next slide is a paper looking at the biofilm producing activity of Pseudomonas aeruginosa from canine ears, and this particular paper suggests that something like 40% of the isolates from these cases of Pseudomonas actually produce biofilm. And of course that radically changes the way in which we want to manage these cases if we know there's such a high incidence of biofilm formation in this particular disease. So the next thing we want to think about is how do we actually diagnose a biofilm infection in practice? When we have a clinical case in front of us in the consulting room, how do we know that there's actually a biofilm present? Well, one of the first indications, of course, is where that infection has failed to respond to what is completely appropriate antibiotic therapy, where we've got cytology or we've got culture and sensitivity. We know we have an appropriate sensitivity in place. We know you've used an appropriate antibiotic, but we still find signs of infection. When you're looking at something particularly from an ear, for example, you'll see they often form this thick, slimy discharge that's often dark brown or black. When you look at cytological sections, you'll often see this thick, veil-like material that will often obscure the bacteria and the cellular detail itself. Often you'll see those bacteria will appear in clumps, and if you use special stains, something like Alcium blue, that will actually stain up this extracellular polysaccharide. And remember, you'll see this not just with bacterial infection, but you'll see it with yeast infection too. We know Malassezia will form biofilms, and certainly we recognise formation of biofilms in otitis externa in the dog. The biggest challenge we face, though, as you can see from our next few slides, is how do we actually treat biofilms when they form. We know that in early stages of infection, where we have planktonic infection and when we have early biofilm formation, then systemic antibiotics may well be useful. But as we've already shown, as we get formation of EPS in chronic biofilm formation, antibiotics are very unlikely to actually resolve that infection. Well, we have things like foreign bodies, so for example something like an orthopedic implant, then it's essential that they're actually removed to stand any chance of resolution of the infection. And what we know now from most current research is that probably the best two ways to resolve biofilm infection is by using topical antibiotics, because they achieve much higher local concentrations than systemic antibiotics do. And also we're starting to recognise a whole range of substances which can be used to break up the biofilm, what I've referred to on this slide as biofilm busting agents. Lots of different things have been described as being capable of breaking up biofilms, and on this next slide here I've just given you 3 papers which I've just pulled from the literature showing you that both silver, honey and povidone iodine all appear to be capable of breaking up biofilms. And this of course is one of the reasons why we see such things as silver or honey impregnated into wound dressings in an attempt to try and break down biofilms in these situations. We also know that TRESI-DTA is enormously useful in breaking down biofilms, and this is another paper again looking at TRESI-DTA in cases of otitis externa, where it's shown to be useful in combination with antibiotics. The results from this particular study are very interesting in that they show that the addition of TRESI-DTA significantly reduces the MIC for aminoglycosides, such as neomycin and gentamicin, but not for polymyxin. And really, quite bizarrely, it shows that the MIC for enrofloxacin is actually increased when TRESI-DTA is added into the treatment regime. Of course, this is an in vitro study, so once we have in vivo results, this may show a completely different situation. But certainly where we're dealing with chronic cases of otitis externa, there's a very strong argument to suggest TRESI-DTA should be a very important part of our treatment regime, particularly if we're using aminoglycoside antibiotics. Our final slide as far as infection is concerned refers to N-acetylcysteine, and certainly N-acetylcysteine is now being widely used, particularly by veterinary dermatologists, as an adjunct therapy in many of the cases of otitis externa, and indeed otitis media that we see. There's very little so far in the veterinary literature, but I've cited here 2 human papers which describe its use in chronic disease, particularly in chronic suppurative otitis media. So if we summarise what we've talked about in the last few minutes, what we should hopefully take home from this short presentation is that biofilms are common in chronic infections, and they're particularly common where we have things like orthopedic implants. What we should also be aware of is the systemic antibiotics alone are rarely successful. Even when they're given at very high dose rates, they just won't penetrate this very thick film, this EPS that these bacteria produce. Topical antibiotics are much more effective in these situations because they reach much higher concentrations locally and they're therefore much more likely to be effective. And of course, the institution of biofilm busting agents, as we've already described, such as povidone iodine, trizidTA, silver, honey, and N-acetylcysteine may be very useful adjuncts in our therapy.